All right. So, good evening, everyone, and hello, Dr. Dhwani. How are you doing?
I'm doing very well. How are you?
I'm doing well as well. Thank you so much for joining us as a guest speaker for today's webinar. That is the perfect 30 minutes RCT. I think this topic seems very alluring for a start. When someone hears that perfect RCT in 30 minutes, ooh, what is it? So I think already our attendees are already very excited to go ahead with this topic. And without wasting the time, I would like to start with a small introduction of our guest speaker. Dr. Dhwani is one of the few dentists who have created a niche for herself as a pain-free dentist. She graduated from prestigious Nair Hospital, top of her class, having 10 years of clinical practice with the majoring in root canals. She started with her journey of trying and testing quicker and less painful techniques to do a RCT. Being a general dentist herself, she was intrigued at how her fellow endodontist finished a root canal in 30 minutes. And that's when she was determined to do the same. She has a successful practice at Matunga, that is in Mumbai, known as Dentist, and Gentle Dental Clinic, where she delivers exceptional quality of dental care in a fun, friendly, and a very compassionate manner. All right, once again, very welcome, doctor. And I think we should start with the webinar without wasting any time. And for all the attendees, while the webinar is going on, if you have any doubts, kindly put your questions in Q&A box, not in the chat box, and your questions will be answered by the end of the webinar. All right. Okay, over to you, doctor.
So hi, Dr. Isha. Thank you for the great introduction. I am Dr. Dhwani Chheda, and I have my practice by the name of the Zentist Gentle Dental Clinic at Matunga. And as you can see by the name, it's Zen. So we want to create a very Zen kind of environment for our patients, and a very comfortable, a very homely kind of environment. That's what we try to do all the time. And I'm going to be telling you about the perfect 30 minutes RCT, a very tried and tested method that we follow to try and make it very comfortable for the patient. And in this time wherein we want to be in least contact with the patient, it's a very good experience for us as well. So let's start.
Please go ahead.
Okay, so today I'm going to be talking about the perfect 30 minutes RC. Now, why do we need a perfect 30 minutes RC? So most of the times we have patients coming into our clinic and they have a question which says that, okay, doc, what is a root canal? How soon can I complete a root canal? Is it going to be painless? So we're trying to attend to each of these questions. Patients want to walk in and out of the clinic as soon as possible, and we want to give them a very painless experience as well. And that's what my course is going to do. My lecturer is going to tell you how we're going to achieve that. Now, the first thing before we start a root canal is giving anesthesia to a patient. When we are giving anesthesia to the patient, we want to make it a very painless experience for the patient. How can you ensure a painless experience for the patient when you're giving anesthesia? Okay, first, most important is we use topical anesthesia. After using topical anesthesia, instead of using an injection immediately, what I do is I use an insulin injection. An insulin injection, what happens is because the needle is really short, you can just anesthetize the area, and what will happen is when you try and use a longer needle, the patient is hardly going to feel the prick of it. So that makes it kind of quite a painless experience for the patient. So you use topical, then you use an insulin injection, just numb or anesthetize the area, follow it with your regular injection. Also, what you do is you continue your injection over 1 minute, as they say, because the longer, the more slower that you inject, the less the pain the patient is going to feel. Okay, so that's the first thing that you do. You try and deliver as painless anesthesia for the patient as far as possible. Okay, coming to the next thing is important thing when you're doing a root canal. Your assistant that you have is to be trained to perfection. Your assistant are your hands, eyes, and ears. Sit with them, try and explain them the whole procedure. So what you think must be handed over to you before you even ask for it. They must know your next step beforehand. And if you train them well, take some time, take a week or so, they'll be able to do it very well. Okay. So this is my assistant. She set up my tray across everything that I need for the root canal. All of us work with a few different instruments here and there. So go ahead, set aside a work list and set aside and ask the assistant to get everything ready at one point of time. Most of us, we either work with maybe one assistant or two or three. Okay. So if you're doing that, you don't want your assistant to move in and around here, getting instruments for you, nor do you want to do the same when you're working on the patient. So have a clean working area, set up everything, have a checklist that the assistant follows, and then begin your procedure. Okay, so the time that the anesthesia acts, I don't include that in the time that I start my root canal. Now, because sometimes nerve blocks take almost like 10 or 15 minutes to act in completely, but that time can be used very much to our benefit. So I have set aside a checklist that you can follow as a doctor, as your chairside assistant, and the other assistant who's helping you. So I work with about 3 assistants, but if you have even one, you can just divide it between yourself and the main doctor. So the first thing that you do is, while the anesthesia acts, is you take an X-ray. Now, after taking the X-ray, your second assistant, they basically measure the length of the root canal. Okay, they measure the length of the root canal. Apart from that, what they also do is they measure the length from the cusps to the floor of the pulp chamber. That is very important in case you have calcified canals, because that will tell you the exact depth that your burr is supposed to drill and prevent a perforation. Okay, so that is the X-ray, and with what your assistant does, your first assistant rechecks the setup tray, saying that you haven't missed anything. You go ahead, you place your rubber dam. Your chairside assistant helps you doing that. Okay. Also, what I try and do with my chairside assistant is I have given her strict instructions that in case she continuously sit with the patient, observe the patient. In case the patient is uncomfortable or having any kind of medical emergency like syncope or epilepsy, she can immediately bring it to our notice if we are a little dizzy. Okay. Coming to the next thing, what you do is, after you have about 5 minutes spare, you can ask the patient to do deep breathing or relaxation exercises. Now, this is something that we specialize in. There are certain tricks that we follow in our clinic so that we make the patient less anxious. Okay, you can follow something similar, and you can also explain the procedure to the patient so the patient is mentally prepared of what exactly you are doing. There's another assistant who can play light music, and you write down, this is an important thing, you write down the tooth number of the chart. You keep that ready beforehand. If you're doing a maxillary first molar, note that down. Now, what chart system we're going to use, I'll take you ahead when we're doing the webinar. Coming to access opening, the first step. Now, access opening should usually take between 5 to 10 minutes. A well-known endodontist has said that access is success, which means get your access cavity design absolutely correct. Everything else will be much easier. How do you do that? The first thing that you do is you select the correct burr. Okay, so you have the burrs that we have that I use are commonly used are BR31, BR41, BR45. Now, if you look at these burr sizes, they basically are from the large to a smaller size. So if you're doing a mandibular central incisor, you will need somewhere between a medium size to a really small burr like BR45. And if you're doing a larger tooth like a maxillary central incisor, or you're doing a maxillary molar or a mandibular molar, you'll need a BR31. Okay, so what you do is you start drilling or start using the round burr. Now, once you have reach the roof of the pulp chamber and you're de-roofing it, once you've de-roofed it, what you use is a non-end cutting tapered Fisher burr, and you flare out your access cavity walls. So good to use these burrs in your practice. Do not use cylindrical burrs. They can cause more damage than actually help you. The second step, so we're going to cover access cavity in 6 steps. We're going to cover BMP in 6 steps. We're going to cover obturation in 6 steps. That's it. You just need 18 steps for a perfect RCT. Step number 2 is going to be intrapulpal anesthesia. as soon as you reach you get a drop, okay, what you do is you take a syringe and inject LA in the pulp chamber. It is going to be painful, slightly painful, yes, but this is something which will be very crucial for you. So prior inform the patient somewhere where you can't avoid it. Prior inform the patient, because this will help you. Once you just inject a couple of drops or a few drops of anesthesia in the pulp chamber and let it be there for a few minutes, the patient is far comfortable, and the entire other process goes in smoothly. The third step number 3, is de-roofing the pulp chamber. Now, de-roofing is something very important because you want to reach out to the pulp horns. You don't want to reach. If you look at the figure number 3 among this, you've removed the pulp horns, okay? Because if you leave pulp tissue there, your root canal is going to be a failure. After you de-roof that, what you also achieve is a straight line access. If you look at figure A and figure B, between the two, okay, in figure A and figure B, if you see, which of it is better? Hello?
Yeah, doctor, you're audible.
I am, yes. I think something just went off.
I think you stopped sharing your screen. No, you're sharing your screen, just the slide. Yeah, you just get onto the slide you were at.
Yes, sorry, I think there was some kind of a problem.
Yeah, perfect.
Okay. So if you look at figure A and figure B, between the two, okay, do you see a difference? Okay, which of it is better? Is the first one better, or is the second one better? Okay, if you look at the two, the second one is better, or rather the dotted line. If you look at the first one, the dotted line, that is over preparation. Okay, do not over prepare in the process of removing pulp horns. Do not over prepare your access cavity walls, because when you do that, as you see in figure 2, you've already undermined a lot of tooth structure, and this is no longer a conservative opening. When you do this, you eventually will have you might have a successful root canal, but the life of your tooth is compromised. So this is very crucial when you're doing an access cavity opening. The access cavity should be large enough so that direct line access to the canals can be achieved, but small enough so that as much of the coronal tooth tissue as possible be preserved. Be conservative. Step 4 is know your root canal anatomy. Now, this is by the textbook. It's been a while since you've gone to your textbook, go back to your textbook, memorize the exact access cavity position. Okay, if you know where your canals are located, you're going to be able to find them easily. If you want to finish your access cavity in 5 to 10 minutes, you must know your root canal anatomy absolutely by heart. Finding canals, I say, are like driving a car. It's only hard till you get used to it. So get used to looking for the canals and you'll be able to find them much quicker. Some points which help you identify your canals easy. I'm not going to go into the depth of all of this. We don't have much time at our hands, but I'm going to tell you about 3 important things that you do when you locate canals. The first most important thing, if you look at this picture, is law of color change. Look at the difference in the floor, and look at the difference in the floor of the pulp chamber, the color of that and the walls. The floor is much darker as compared to the walls. So that is how you will be able to identify. That's one very important thing. Second thing is, of course, law of symmetry. So if you in case of a mandibular first molar, your mesiobuccal and your mesiolingual will be at an exact same distance if you draw a line through the mesiodistal axis of the tooth. Now, why is it important? Is sometimes you just end up finding one mesiobuccal, you're struggling with the other. You know that if mesiobuccal is at a particular distance, mesiolingual will be at almost the same distance that the mesiobuccal is. Okay. And the third most important thing is, all the canals are located at the same depth. So when you are finding your canal orifices, if you find, like, the easiest to find are, of course, the larger canals like palatal or distal. Find those, and at the same depth, search for the others. It's very textbook. Step 5, it's my favorite part of it. I stress on reading the dentinal map. Something we do a lot in the course that I conduct. I teach students how to read the dentinal map. Now it's very important. See, when you drive your car, you are riding across a road. You have a road map. So does your tooth. Every tooth has a dentinal map. It's very important that you start noticing dentinal maps early in your practice, because what will happen is it will make your root canal far easier. Okay, do not drill through the floor of your pulp chamber. If you drill through the floor of your pulp chamber, so as soon as you get a drop, you de-roof your pulp chamber, you use sodium hypochlorite, you remove the pulp tissue from the pulp chamber, use a spoon excavator, however you're comfortable with, and uh, try and make the floor of the pulp chamber as clean as possible so that you can spot the dentinal map. The dentinal map will tell you exactly, you just have to follow the map and it will tell you where the orifices are located. Very important trick in quick root canals when we're doing quick root canals. And the last step of access cavity opening is going to be cuspal reduction. Now, reduce. So, cusps, it's very important that you reduce your cusps, okay, at least about an or so. What happens is any tooth which is indicated for root canal is usually infected. And when it is infected, it is under a lot of stress and load. If after doing the root canal, you do not reduce the cusps, patient is usually going to come back with a lot of pain, and that's going to create a very uncomfortable experience for the patient. So do not forget to reduce the cusp, and reduce the cusp prior to taking the working length. So with your cuspal reduction ends your access opening. 6 easy steps for your access opening. But of course, there are tricky access openings. You can't say every access opening I'm going to be able to do it in 5 or 10 minutes. You must know. But to see, to spot even the difficult ones, you must know beforehand that this tooth could have something a little more difficult, and then you will be able to work on it. So your eyes can't see what your mind doesn't know. Okay, tricky root canal openings, you must already be aware that this tooth might have a complicated root canal opening, either because you've studied it prior, you know these. I'm going to be covering the three, you can't cover everything. I'm going to be covering 3 teeth which have tricky root canal openings. And also what you can do is you can take x-rays in particular teeth. When I go ahead, I'll be telling you, you take multiple x-rays and you rule out multiple root canals in the same tooth. First, of course, is a question that's always there before us, whether we can locate the MB2. Yes, you can very successfully locate the MB2. 70% of your first maxillary molars have an MB2. Sometimes they have even 2 of them. Okay. I have done a case wherein I have had 6 canals in the maxillary first molar. So they are easy to locate once you get used to them. MB2 especially, you must, because if pulpal tissue, if it is an MB2 which is joining the main MB canal, you're maybe lucky. But if it is not, if it is an entirely separate MB2 canal, if you leave pulpal tissue, your root canal is going to fail and flare up. Okay, so how do you locate the MB2? Very simple. We'll go on the most simplest way of locating it. You have a buccal and the palatal. From the buccal to the palatal, draw a straight line across. Your MB2 is going to be slightly more mesial to the line drawn to it. It is going to be somewhere closer to the mesial marginal ridge. Okay, that's when you're going to find your MD2. Take a sharp probe and try and access it. Now, the second important thing is mandibular incisors. The second tricky teeth are mandibular incisors, mandibular canines. Most importantly, forgot. So what we do is in these teeth, we find one canal and we're very happy. Oh, we've found out one access opening. No, mandibular incisors usually in almost 50% of the cases will have 2 canals. Okay, so in this particular tooth, how you see, you've taken a drop in the pulp chamber, you found the buccal canal. Once you find the buccal canal, always carefully enlarge your access opening little more lingually. When you enlarge it lingually, there is a very good chance that you will find your lingual canal as well. Okay, so mandibular incisors and mandibular canines, look for 2 canals. And third is mandibular first premolar. I'm covering up only the three teeth which have most likely variations. All the other teeth also could have a lot of variations, like mandibular second molar could have C-shaped canals and a lot of other variations which we can't cover up in the scope of this time. Now, mandibular first premolar, if you look at a mandibular first premolar, if you see 58% it has a type 5. Type 5 meaning you have a single canal somewhere in the middle of the canal, it splits into two separate canals. Now, access cavity and BMP will still be easier in such canals, but obturations, especially if you're not using an obturator, it's going to be tricky, it's going to be quite difficult. Okay, so that is something which we can learn in detail. Okay, but be aware that when you're doing a mandibular first premolar, when you're doing mandibular incisors, take x-rays. Take x-rays, one from the mesial, one from the distal direction. Take it from a couple of directions so that you are sure you have not missed out any canal. Okay. After this, another important tricky thing is if you are looking for calcified canals. Now, calcified canals, what I suggest is using a DG16 Endodontic Explorer. All of us must have them in our practice. Not very expensive, but a very handy tool. A catch with a DG16 will easily be able to help you find calcified canals, also knowing the location and knowing the anatomy. Okay. The next is pulp stones. Here again, you might take longer than expected when you're doing an access opening. First, most important thing when you're doing pulp stones is always on your x-ray. Your x-rays are very important. That 15 minutes that you've injected the patient, use that time well and study your x-ray. So in that x-ray, in this x-ray, you can clearly see to the right that you have large pulp stones in the pulp chamber. So after you take the drop as well, you might or may not be able to gain access into all your canals. So in that case, you can either remove the pulp chamber, you can either remove the pulp stones. I sometimes use a probe. If it's easily accessible, you just try and just move it around, juggle it around a little bit with the probe and try to remove it in toto. Or sometimes if that's not possible, what you can use is you can use ultrasonics. You can use an ultrasonic scaler tip in and around, and slowly around the, what you feel is the pulp stone, slowly move your scaler tip around and try and tease it out. Okay. If sometimes you're not able to, consider you're not able to remove your pulp stone, you can use a micromotor at a slow speed and try and remove it. Irrespective, if you are able to gain access into all your canals and your pulp stone is still in place, if you are able to gain straight lines, sufficient access into all your canals, what you can also do is try and flare them up a bit, try and flare your canals up a bit. Once you flare your canals out, your pulp stone will invariably become loose and you will be able to tease it out. Okay, so this covers your first part, which is access opening. Let's come to biomechanical preparation, or BMP. BMP ordinarily should, something that we more commonly call as cleaning and shaping, should ordinarily take about 15 to 20 minutes. Now, why do I say 15 to 20 minutes? That is, if you look at a lot of great endodontists like Mohammed Hamo, he will always tell you that 20 minutes is the amount of time that sodium hypochlorite must be in contact with your canals. That is the amount of time it will take to dissolve all your pulpal tissue. So, BMP should take about 15 to 20 minutes to complete. And it can be realistically completed if you follow all these steps. The first step is scouting the entire canal length with a 10K file. Now, what is scouting? Scouting is just a more refined word for saying you just check the patency. Now, remember before I told you that your assistant has already given you a canal length. So you already have an approximate canal length with you, and you can subtract 1 to 1.5 mm out of it because you did cuspal reduction, you remember. So assuming your assistant gave you a length of 20, about 18.5 or 19 is what your 10 number K file should be able to go in the entire length of the canal. It's okay if it goes 0.5 beyond. A 10 number K file will not cause much harm. But what it will help you to eliminate, it will help you to check if you have any curvatures, irregularities, calcifications. So immediately the first file that enters in your tooth is a 10K file. If by chance your 10K file is not able to enter in the length completely, then you know that something is off. Okay, there is something which is either I have a curvature, either I have a calcification, there is something which is resisting my file to reach the full length. So you accordingly, now in step 3 and 4, I'll tell you what you can do, and you can get an easy access. Even in spite of having curvatures, you can get an easy access. Okay. Step 2, this is one of my favorites, which says follow the rule of opposite during access into the canals. So I've seen a lot of, even whenever I was very initially practicing, we struggle. Okay, when into our first few root canals, we struggle. You try and put in, if you're doing an MB, especially if you're doing a maxillary or a mandibular molar, whether it is a GP, whether it is your file, you struggle when you're trying to put in a mesiobuccal a file into a mesiobuccal canal or a distobuccal canal. Palatal is easy because the canal is large. Okay, so but that's very easy. What you have to do is, if your canal, what is the opposite of palatal? Palatal's opposite is buccal. What is the opposite of mesiobuccal? Mesiobuccal opposite is distopalatal, which means if you have to gain access into the mesiobuccal canal, your file direction is to be distopalatal. That's it. Okay, if you have to gain access into the distobuccal canal, your file direction is mesiopalatal. So in your mind, rehearse it. Say that when you're putting the file, 100% you will be able to gain access into your canal. Okay, so this is something, even the most complex of the canal, because smaller files like 10 number K file, even if you randomly just wiggle, you will be able to gain access to. But once you have larger files or you're using rotary, you can't, you don't have much room to, just experiment. So you have to be very sure of the exact direction. The only difference will be that some of them will be rather straight line, some of them will be rather more tapered. Okay, so that is something that you should do when you're finding your canals. Step 3. Step 3 is determine working length. Now, I am talking about a scenario wherein you have achieved patency, your 10 number K file has gone the full length of the canal, and you have, then in that case, you can determine the working length. I usually advise when you're using, I usually advise you should invest in an apex locator. Now, I have a J Morita, but even if you are using an apex locator which is not as expensive as J Morita, there is still a way you can achieve a very good working length with an apex locator, even a basic one. Okay. Also, there are certain tips and tricks where you use apex locators. Please read through them. Now, when you're using an apex locator and you're determining working length, most important is when you take your file and you go slightly beyond the apex. Okay, it will give you that continuous beep, which means that you've gone beyond the apex. And after you've gone beyond the apex, you retract the file slowly and you try and reach at the apex or 0.5 short of the apex. I prefer 0.5 short of the apex. This is a much more accurate way, whichever apex locator you're using, because all apex locators work on the same principle. They complete the circuit, right? So if you have gone beyond the apex, your apex locator is completing the circuit. So you go beyond the apex, just try and go in just 0.5 beyond. The apex locator will immediately give you a beep, retract your file 0.5 short, and that is going to be your working length. In case you're not using an apex locator, your radiograph will help you in determining the working length. Okay, when you are when you are recording the working length, it is very, very important that you have a stable reference point. That's when we said that when you have a cuspal reduction, you remove unsupported tooth structure, as you see in figure A and figure B. Figure A as unsupported tooth structure is going to give you your file stopper, which is going to be at a cross or at an angle. You rather want the file stopper to be smooth so that it can give you a much more stable reference point. 0.5 mm can also be very crucial when you in over preparing, in over obturating. So try and get as stable a reference point as possible. Now, I have a very unique way of noting down the reference point. What I do is, In my assistant is trained in writing down tooth numbering system, so she will note down it's a maxillary first molar. What she will also record is the length. If it's an MB, MB2, you just tell her that, okay, MB itna hai, MB2, this is distobuccal, distopalatal. You also have to mention the reference point. Why is it so crucial when you're using? What is the reference point? Now, reference point is the point wherein the stopper is touching or contacting the tooth. From there till the end of your, till the reading your apex locator is giving you. Why is the reference point crucial? Today, for instance, you recorded a working length of 18 mm, but your reference point in case of a palatal canal was your rubber stopper was contacting the palatal cusp. Today, for some work, you are not able to, you have your associate or you have someone else completing the root canal for you. You have written 18 mm as your working length. Okay. They measure 18 mm from the buccal groove. Now, when you've measured it from the buccal groove, it would ideally be, your file would ideally be shorter because your length of the file is increasing, and you'll have a wrong reading. Sometimes in that way you can kind of over prepare. So what you do is you have to have stable reference point even for your reference. Sometimes you're seeing the patient, if you're giving a calcium hydroxide dressing or seeing the patient after 3 weeks, you don't really remember the reference point. So noting down the reference point really helps in when you're recording the working length. Step 4. Step 4 is irrigate, irrigate, and irrigate. Okay, they always say that for better results, thorough cleaning of the root canal is more important than shaping. So, cleaning of your root canal. How is your cleaning of your root canal achieved? With irrigation. What do you irrigate with? 5% sodium hypochlorite. Use concentrated 5% sodium hypochlorite. Use rubber dam, have an assistant, use a suction exactly on the top of your tooth to suck out your sodium hypochlorite as soon as you inject it in the canal. How can you increase the efficacy? Now, especially because you're going to be working in the canal for only 15 to 20 minutes, a very short span of time. You don't have multiple visits. So how can you improve the efficacy of sodium hypochlorite? First, you heat the solution. So constantly keep on changing your syringes, heating. Use heated up sodium hypochlorite will give you maximum efficacy. Volume of solution, use a large volume of sodium hypochlorite when you're injecting it. Large does not mean forceful. So be gentle when you're irrigating with sodium hypochlorite. If you inject with force, your patient is going to jump in your chair. Okay. And the third most important is ultrasonic activation, as in the picture that I'm showing you now, that you activate. So I have an endo activator. A hack for it is using a water pick. So use an endo activator. What you do is with an endo activator, activate your solution before you obturate at least, so that you have maximum efficacy of sodium hypochlorite. You're able to reach the accessory canals as well. Decreasing sodium hypochlorite efficacy. Now, decreasing is storage time. Okay, do not stock too much of sodium hypochlorite. Once you open the bottle, try and use it up as soon as possible, because the longer that you keep it, the more exposed that you keep it, your efficacy is going to go down. And EDTA should be used mostly when you're using rotary instrumentation. Try and avoid it try and use minimum of it when you're doing the first steps of access opening in DMP. Step 5, pre-flare the coronal third and establish a glide path. Now, something that I use to hasten up my speed and work very quickly are these handpieces. You can use any K-filed handpiece that you have. Instead of hand motion, you have a machine which does your work. It's far quicker, okay, and it's more predictable. I am very comfortable with using them, and they're not very expensive. It's a boon in your practice. So if you're not using one, I suggest, if it works for you, you should invest in one. Now, mimics, the advantage of using this is that when you sometimes use a K file by hand, you end up using an entire circumferential motion, and your file can break in that. Whereas this has a typical watch winding motion. It saves time, it reduces fatigue, and it makes your root canal far more economical also, because it makes it far easier. Now, how do such handpieces work? What you are supposed to do is, if this is your canal that's there, you take your file and you just move it laterally along the entire canal, and along your entire canal. You just laterally brush the walls of your canal. When you laterally brush the walls of your canal, what you're actually doing is you're essentially increasing the diameter. Now, when you're increasing the diameter, not only is it easy for your next file to go in, like a larger size file will easily be able to go in the length of the canal. Also, more amount of irrigant will be able to go in through the canal. Okay, so remember that particular point of time wherein I told you that what if a 10 number file is not able to go into the entire length of the canal. So don't worry. If your 10 number file is able to go maybe say 3 mm short, what you do is, with a 10 number file, first till that length that it's able to go in 3 mm short, you first you just use a brushing motion, you increase the width of it. Then you use a 15, then you use a 20. Till that length, don't force your file. Once you do that, you've created more space for your, and easily after you do that, your 10 number file will be able to go in that canal, because you've already increased the diameter of that opening at that particular point. It was a curvature, but you've increased the width. So now a smaller file is able to go inside. Okay. Now what you have done is, you've established a glide path. Glide is smooth. So you've established a smooth path for 10 number, 15 number, 20 number. I usually prepare till 20 number. A very smooth path with 20 number takes about 5 minutes or so. So from the cusp tip, or from your reference point till the apex, you have achieved a smooth path that you've prepared with 20 number K file. And that is far more sufficient when you're using a rotary file system. Your 20 number K file, if it's loosed inside the canal, it is your rotary file system will easily be able to go, and you'll have less number of breakages. Rotary file systems. Now, when you're using an endomotor, you can either have an active or a passive file system. Okay. We different file systems, like pro tapers are passive file systems. File systems which are one or two file systems, like the files which come by Bombay Dental Surgical, or one or Wave One, they're all active file systems. Why active? Because they have much more cutting efficiency as compared to passive file systems. Okay, so they are much more quicker in general. So when you're using an active file system, it's easier because you're investing a lesser number of files also. I prefer that, though it's personal preference. What I use is a lateral brushing, upward brushing motion. Basically, you're using a crown down technique. You are using the file laterally upward. You're just brushing against the same thing that you did with an endomotor, the same thing you're achieving with the file. You're just using a lateral upward brushing motion, okay, with the file, slowly, not allowing the file to get locked into your canal at any point of time, and slowly from crown down. So from the top of your crown, you're going down towards your apex. Recapitulation, extremely important. When you're using a 10 number, 15 number, 20 number, you're using an endomotor, using rotary. Between each file, you must irrigate, and you must use a 10 number K file, as we did at the start, to check the patency. Okay, your 10 number K file must go in through the full length of the canal, and you should, because you could leave any kind of if there's any kind of debris which is left behind, it will clog and unnecessarily create a problem later. And using the correct torque and speed, very important. Any particular file system that we are using has a torque, and a predefined torque and a speed that the company has. Make sure you remember the torque and speed, paste it across somewhere. I have it pasted on my chair so that I can see it every time that I'm working on. If you use, most breakages happen because you're using a wrong torque and wrong speed. With every file system that you are having, please go and check across and use the correct torque and speed. And the last one is disposing the file after 6 to 7 uses. Now, depending on your practice, you can dispose it after 1 use, you can dispose it after 2 uses. If you are, sometimes we dispose it after 1 use completely. Okay. If you want to autoclave the file and dispose it, an ideal thing, if you want to use your file for a little longer, you should dispose it after 6 to 7 uses. But my point is, if you're using a file more than once, or if you're using, we have multiple files, okay, we have 10 different files that we stock with us. How do I know that I've used this particular file 6 times, I've used this particular file 2 times? Okay, what I do is I color code my rotary files. If you look at this, if you look at pro tapers, what I have done is, if you look at all the pro tapers, look at the simplest one, the pro taper. All the pro tapers are white stopper. There's a different file system which is a blue stopper. There's one which is a yellow stopper. So every file set that you're using. So if one of my pro tapers has a white stopper hand pro tapers, there'll be another hand pro tapers which is a yellow stopper, another one which is a red stopper. So what will happen is, every time that I use a white stopper file, the minute I use the file for the first time, my assistant has already made a note. My white stopper file has been used 7 times. You cross it out against first, second, third. So I remember I haven't used one file more than 6 times, 7 times, for however long I want to use it. Okay, this prevents file breakages and helps you to keep a count of how many files also you've used. Okay, so that is done, simple, easy biomechanical preparation, BMP. Okay, coming to the last part, which is obturation. Obturation should take you about 5 to 10 minutes to obturate. Okay, first most important thing when you're doing an obturation is dry the canals well. Be liberal in using paper points. Do not hesitate. Have your paper point be absolutely dry before you obturate. Also, your paper point, sometimes what happens is you have a bleeding point which comes at the end of a paper point, very crucial, because at the next step when you're using a master bone, it will tell you exactly that it's gone beyond, it hasn't gone beyond. A paper point will tell you if it's gone 0.5 beyond, you know that you've over prepared the canal by 0.5 mm, and that is what you will be careful when you're using your gutta parcha. Step 2, very important, to do an apical gauging. Now, what is apical gauging? Apical gauging means if today I have prepared my canal with a 25 number 4%, which means my apical diameter is equivalent to a 25 number K file. So what I do is I use a 25. If you look at figure 2, you have a 25 number K file, NITI. You have a 25 number K file. What I do is I insert it in the canal and I lightly tap it. Okay, when you lightly tap it, you should see whether it is going to what length. Basically, that light tapping is to see till what length is it going. If that file is going, if your working length was 18 and that file is going to say 18.5, which means your apical diameter is 0.5 more than what it is supposed to be, which means even if you might get a tug back with a GP, which is a 25 number 4% GP, it still will not be right, because your apical diameter is essentially more and you will have space at the apex, which you do not want to have. So what do you do in that case? In that case, if you have a file which is going beyond 25 number 4%, you know it's going 0.5 beyond. So I cut my GP 0.5 cut my GP 0.5 short, so that I know that my GP isn't going to go beyond. If I push my GP beyond, it's going to be a whole different story. It's going to be a real big problem later on. Okay. This is what could happen. This is what could happen if you push your GP. Now, in this case, the GP has gone right beyond the canal. It has gone into the inferior alveolar nerve space and too many complications. So do not over obturate your canal, and very important to do apical gauging. And step 3, which is tug back. Tug back means you're tugging something. Okay, tugging something means it has to bind. But where does it have to bind? It has to bind in the apex. It does not have to bind in the middle third. Okay, true tug back, false tug back. False tug back is when it is binding in the mid third. True tug back, it is when it is binding in the apical third. Okay, you should have that resistance which is coming in the apical third. Okay, even if you look at the picture to the right, it says if a crimping is happening in the middle third, which means somewhere something is wrong, go back, see what step you've done wrong, come and correct it. Apical third, if you're having crimping, which means it's binding somewhere in the apical third, though ideally should have just a tug back, should not have crimping anywhere, but this is just to show you that if crimping is happening in the mid third, which means you have to go back and probably flare your canal enough for your GP to go in, or use a smaller size GP. Step 4 is your master cone X-ray. After you have completed all this, take a good master cone X-ray in case you're doubtful. If you're having overlap anywhere, re-verify length using an apex locator. Step 5 is using a good sealer. You can either have a calcium hydroxide sealer, you can have a resin-based sealer, you can use bioceramic sealers like CeraSeal, which have come into the market. Okay, and coat your sealer well. You either buy a gutta percha, buy a file, buy a lentil spiral, whatever you're comfortable with. And last and most important, condensation of GP is crucial. Okay, so whenever you are having gutta percha, make sure you have condensed it well in the canal. Use whatever you're using. If you're using cold lateral condensation, if you're using warm condensation, condense it well in the canal. Okay, avoid any voids that are coming in the canal. Okay, it will not only help you have a good it'll prevent any microorganism, because there are sealers like Sealapex that we talk about, calcium hydroxide base, which are antimicrobial. You have a lot of antimicrobial sealers. So when you compact and condense your canal well, you will prevent any voids, you will prevent any bacterial invasions as well. And last and most importantly, have a clean pulp chamber. Okay, so in the pulp chamber, if you look at the left, many times what happens is we come across, or we ourselves leave a very messy pulp chamber. Now this is not only the gutta percha is a very weak material. If you leave so much in the pulp chamber, you'll have less space for your actual filling material, which is to provide the strength. Ideally, you're supposed to share off all your GP till the CEJ, share them off well, have a clean pulp chamber, and then use your do a good restoration. Okay, do a good permanent restoration, and follow it with permanent filling, follow it with a crown, follow it with an onlay, however you intend to. Okay, and seal off the canal well. Do a good permanent restoration. If you do a very leaky restoration, it will again cause seepage into your canals and can damage the further life of your root canal. So that's it from me for a perfect 30 minutes RC, achievable, practical, and very comfortable once you get used to it.
Right. Thank you so much, Dr. Dhwani. It was a great presentation. And also, I would want to ask or probably add that all this will actually come through practice, right? Like you have to keep practicing.
It will come through practice. It will come through a good learning also. So you can do a good course. You can do a good course with me, or with anybody you're comfortable with. What will happen is we teach you a lot of. So you can't cover up a lot of this in just an hour or so. So we teach you a lot of other tips and tricks that go along the way, and of course practice. But the right knowledge and practice, both of it will help you achieve it.
Certainly. All right. Thank you so much for delivering a commendable webinar with us. And now I will, can you please stop sharing your screen? I need to present a small presentation.
Yes.
Okay. All right, guys. So I will start with a small presentation that is okay, so I'd start on what is DentistChannel.Online. So we are India's largest digital dental media company, and our motto is to provide such platforms to the growing dentists and to promote dentists, basically dental surgery as a profession, and support all the doctors who are already doing super well in their own personal clinics. Further, you can save this number and you can reply with your name so that you will have all the broadcasts. You will receive a broadcast message on all the upcoming webinars and workshops with us and whatever events are coming up. After that, this is our Instagram handle. So rush, go and follow it right now so that you know exactly what is going on with us, what events are coming up, what new projects are coming up, and you can be a part of it. So go and like this follow our Instagram handle. Okay, so I'll just mention a few upcoming dental workshops we have. That is one we have with Dr. Arun Srinivasan, and Dr. Aditi will be hosting it. This is, I'm sure it's going to be a great workshop because I personally know Dr. Arun, and he's a great speaker and he has a lot of knowledge in what he's teaching in this webinar. Then these are further our upcoming webinars, and you can have all the information about them, or if you want to register, you can register them on our website. Then be a Prime member with Dentist Channel Online. Okay, to all the attendees, let me just inform you that you all be getting e-certificate only if you are a Prime member with us. So make sure that you're a Prime member with us, and it will cost you very minimum amount of money, and that membership is valid for the whole year. So for the whole year, you can attend n number of workshops, n number of webinars with us, and you will be provided with the e-certificate of that. So this is our website, that is www.DentistChannel.Online, and you can go ahead and please follow us and be a Prime member so that you can get an e-certificate. And now it is the time for the Q&A session. Okay. Okay, so there is one question, Dr. Dhwani. This RCT in 30 is good for acute pulpitis so that we can perform it in the case of periodontitis.
So periodontitis is to do more with periodontal issues. But if you have periapicals, I do not suggest doing 30 minutes RCT. This is a very broad idea of most that come in our practice. You can also have, if you are having a patient who is having a more chronic condition, what you can do is you should have calcium hydroxide dressings, leave in the calcium hydroxide dressings for 8 days, 15 days, depending on when your canal is dry. It's very important that your canal be dry when you obturate. And it depends case to case, but most of the cases are manageable. Chronic cases, you would want to wait and give a calcium hydroxide dressing.
Okay, perfect. I hope the answer, you've gotten your answer. All right, so there is one more question that is by dental student. What he's saying is that should I use rotary foil files or should I use manual files? Or I should use warm compaction to achieve 3D obturation or lateral compaction as what I have been taught at school?
Okay, so should you use rotary? Should you use hand?
Yeah, rotary or manual, or shall I use warm compaction or lateral compaction? So he wants answer to both.
Difference between. Okay, so you should start. It depends on how many root canals you have done. In the very first few cases, I suggest using hand files, just that so you tactile, so you have an understanding of how exactly your file is going to go in. Okay, once you've done a few cases, you can move to rotary, not a problem at all, because we train in a particular it's not that difficult if you follow certain steps, if you have follow certain precautions, if you if your file doesn't bind in the canal, if you learn the tip and trick of it, it's easy using rotary as well. It will save a lot of time. And also what happens is, as we age up in our practice, by using our hands continuously for a very long time, I have had a lot of friends who've developed carpal tunnel syndromes, and so we want to preserve our hands. That's our bread and butter. So it is better to move into rotary systems once you get used to it. And whether it comes to using warm vertical condensation or using cold, it also depends on how much you invest. Now, if you have an obturator, if you are investing in a lot of equipment, it is obviously better to use warm vertical condensation, because in that way you will be able to cover and fill in the accessory canals as well. But at your start, you can achieve very successful root canals. If you don't want to invest a lot, you can achieve very successful root canals by cold lateral condensation also. Cleaning and shaping is far more important as compared to obturation.
Okay, there's one more question. How will we know the working length and irrigation in the case of open apex?
It is hard. Okay, what you will need to do in case of an open apex is you have an initial working length, then you form a barrier. Once the barrier forms, what I have seen in a lot of these cases also is that the length of the canal changes once the apex formation happens periodically over a matter of months. The canals tend to get a little smaller in size, so you will have to re-monitor and re-evaluate the working length after every time that the patient comes in, or every couple of times the patient comes comes in, because this is going to be a long-term procedure. When you talk about an open apex, or when you talk about an open apex, is going to be usually having a huge periapical or some kind of a lesion around it. So the healing time is also going to be larger. So keep on re-evaluating the working length, and use an apex locator just before you obturate at the last sitting that you're obturating, to give you a better working length.
Another question is, after root canal treatment, do you think crown is the only option? Can we go for onlay in order to save some tooth structure?
I mentioned that. It depends on what you are going in. You can do onlays, you can do crowns. Sometimes if it's a very conservative opening, you can do a very good high strength filling as well. So it depends on what you plan or intend to, because you are the best judge. You've seen the case from the very beginning.
Perfect. Okay. This person wants to know the best calcium hydroxide can be used for canal dressing.
Which is the best? Are you asking me for a company? Okay, so I usually prefer calcium. I usually prefer a calcium based sealer. Which calcium hydroxide did you say? Sorry,
yeah, best calcium hydroxide.
Most of it. So if you ask me very honestly, calcium hydroxide powder and saline also is excellent. Okay, it's going to kind of serve the same thing if you know how to condense it. So when I pack calcium, it's more important the technique of packing calcium hydroxide. See, when I usually pack calcium hydroxide, I take an X-ray. That is, after I pack the calcium hydroxide, I take an X-ray, and my X-ray, you will be able to see the calcium hydroxide packed as well as you would take after an obturation. You have that good an X-ray between the difference that you'll be able to see. It's that well thoroughly condensed. So how you pack the calcium hydroxide is going to be far more important. All brands that come in are good. I think if you are at the start, even the Prime Dental one that comes is good, or you can use an Avucal, you can use Dentocal. There are so many different brands. You can use an expensive one like Septodont or Ultradent also.
Another question, by increasing the temperature of sodium hypochlorite, are we not changing the nature of the chemical product?
No, you're not. It is very well tested. It is very well. Most higher endodontists also use hot hypo. It's a very common. It's very, very commonly used. It increases the efficacy, especially because if you are working in a short span of time, you want the efficacy to be the maximum. So you're not changing the chemical structure.
Do you use ProGlider 15/2% in thin canals? Can this be done away with using 15K handle file in reciprocating HP for thin canals? Which one is faster and safer?
Which one is faster and safer? So, ProGlide or a normal 10K. So I always prefer reciprocating handpiece even in thin canals, because what happens is, even when you are using it, it depends on, first of all, how thin your canal is. If your canal is extremely thin, you will first have to just try and have a tactile access using a normal K file. But using a reciprocating handpiece, if you are used to it, it is very, very simple, because you will very quickly be able to enlarge the access of your canal. And once you are able to enlarge the access, you will be able to put in a 10, 15, 20 and so on and so forth. So using a reciprocating also is not a problem at all.
All right. Which one is better, calcium hydroxide or triple antibiotic paste?
Depends case to case. So I had a particular case wherein there was a patient, we were giving calcium hydroxide dressings for almost 2 months, and the periapical wasn't resolving, and we were doing everything right, absolutely strict isolation, everything right. But there was so much of pus, because the pus buildup was over years. So we actually had to aspirate the pus. After aspirating the pus, we had to give in a triple antibiotic. Now, the problem with giving a triple antibiotic is that it many times stains your tooth. Okay, so there are certain tips and tricks in using a triple antibiotic. You can change the composition in a particular way that it doesn't stain your tooth. You can use it. What happens in general is, you change when you use a triple antibiotic or use a calcium hydroxide, you change the medication that you're using inside the canal. So if that bacteria, if your bacteria is sensitive to triple antibiotic, it is going to act, it is going to work faster than it is going to, but till you try, you will not know. Use calcium hydroxide as your first aim. If it does not work, then think about triple antibiotic.
Very well answered, ma'am. Next is there any alternative to NaOCl for irrigation?
No. Stick to sodium hypochlorite. See, alternatives, you can use liquid EDTA. So I have liquid EDTA. I have 2% chlorhexidine also that I use to dry off my canals, but none of it. So they can be used as an adjunct or along with sodium hypochlorite. Okay. But the main irrigant has to be sodium hypochlorite only.
Okay. Okay. The last question. If we are not using rubber dam, should hypochlorite be used in diluted form?
No. So sometimes in some particular cases, my patients are not comfortable with using a rubber dam. So I cannot use a rubber dam in each and every case. Sometimes access is very, very difficult. So what what you must do is when you're using a hypochlorite, the chance of it falling in the patient's mouth is very high. So you build up your tooth. You build up your tooth. If it is one of the two of the walls which have already been fractured, you build the sides up with a filling material, with a good filling material, and then ask the assistant to hold your suction, high wax suction, exactly at the crown of the tooth, and suck out the excess hypo. So it's not going to be a problem.
Why not use EDTA during initial instrumentation?
You can, but EDTA will decrease the efficacy of your sodium hypochlorite. And EDTA for a very long time, if it is in contact with the tooth, it also ends up making the tooth a little softer. So dentine a little more softer. So try and use it with your rotary instrumentation. Try and minimize its use and let sodium hypochlorite alone affect and remove as much of the pulp tissue as possible.
Right. Perfect. I think that's all for today. You answered all the questions very, very well.
Thank you very much.
And okay. Last question.
Yes.
What can be done in case of ledge?
Ledges now, so they're hard to treat. Don't create one, so you don't have to treat one. That's something that I'm just going to tell you. But ledges,
something similar to instrument separation.
yes, that's what I when I was talking about in my lecture, I was saying that don't push your file. You know, if your file is if your file is 2 or 3 mm short of the working length, don't push your file beyond that. You might end up creating a ledge. How do you treat it? Yes, then you have to try and bypass it, move in and around the ledge. It's a whole new lecture.
All right, Doctor, nice to have you on board with us, and thank you so much for delivering an amazing webinar and also answering all the questions very, very well. And we're looking forward to have more webinars with you. And I think that's pretty much it. And I would request all the attendees to become a Prime member so that you can be awarded with a e-certificate and follow our Instagram page for getting the updates. Keep on visiting our website, and that is pretty much it. Thank you for all your support, attendees, and I hope you love the webinar with Dr. Dhwani. And thank you again, Dr. Dhwani. I think we're going to end it now.
Yes.
All right. Thank you so much. Bye-bye.